Hello, everyone, and welcome back. I'm Joe Chappelle, and you're listening to episode 72 of the OBGYN podcast. Today, I'm finally fulfilling the promise I made way back in episode 62 to come back to diabetes and pregnancy. Now, I just looked, and embarrassingly, that episode came out over a year ago, so we're going to have to file this one under better late than never. Before we do get started today, a couple of quick updates. The Discord server's up and sparsely attended so far as predicted, but if you are interested in connecting with myself, the other hosts, or other listeners, then please come join us. It's free, it's easy to set up. The link is in the show notes or on the homepage at www.obgyn.fm. Second is that we are continuing to add transcripts for past episodes, which are also available at the bottom of each page on the website. So if you're looking for transcripts, please go check them out there. And with that, let's get started with Diabetes and Pregnancy, Part 2. Now, if you recall, back in episode 62, over a year ago, as I said, we talked a lot about insulin, and I want to start this episode going back to Banting and Best. As you'll recall, back in 1921, they figured out that they could extract pure insulin with less work by using fetal calf pancreas instead of dogs, because fetal calves don't produce the enzymes that degrade insulin, and that's what had made their earlier dog work so difficult. So that year, they took their findings to McLeod, who, if you remember, that's the lab they were working in, and he recommended adding J.P. Collop, a local biochemist, to help with the extraction. Now, as we spoke in the last episode, in January of 1922, they injected a 14-year-old boy at Toronto General Hospital, and unfortunately, although they did find a little effect, he had a severe allergic reaction. So J.P. Collop then took the next batch of insulin and used an acid alcohol to help precipitate the insulin, while leaving the impurities behind. This injection worked wonders, and the rest, as they say, is history. Now, the four researchers, Banting, Best, McLeod, and Collop, who, by the way, argue vehemently over who got credit for the discovery, now they had a world-changing medication, and they had no way of mass-producing it. So in May of 1922, they partnered with Eli Lilly, an Indiana-based drug company who still makes insulin today. In 1923, they discovered an improved method to isolate the insulin protein by using isoelectric precipitation. What is that, you ask? Well, every protein has its own isoelectric point. That's the pH at which the protein has no charge. So above that, it's negatively charged, and below it, it's positively charged. At the isoelectric point, the electrostatic repulsive forces are eliminated, and the target protein aggregates and precipitates. This allowed the chemists at Eli Lilly to make incredibly pure insulin. Now, the other company that was licensed to produce insulin was Nordisk in Copenhagen, and they began production in 1923. This part of the company later got spun out as Novo Company and then later reintegrated to form Novo Nordisk, which may or may not sound familiar to you. It's amazing to think that the first human injection was in January 1921, and that by late 1923, insulin was available in all of the Western countries. And all this happened without them even knowing what it was. In fact, it wasn't until 3 years later, in 1926, that J.J. Abel at Johns Hopkins was able to crystallize it and determine that it was, in fact, a protein. All right, well, now that we had the insulin, of course, what happened? Well, patients started to complain about it. The major complaint at first was that, quote-unquote, regular insulin had to be taken multiple times a day, which was inconvenient and required lots of supplies. Throughout the 1930s, many different attempts were made to prolong the action of insulin. It was emulsed in oil, it was injected with vasoconstrictor, combined with an almost tissue-involved insoluble solution. The last method was actually studied in Copenhagen and led to the idea that by making the insulin more basic, as opposed to the acidic insulin hydrochloride, it may degrade at a slower rate. The research team hit upon using a protamine, which is basic and insoluble. The idea here is that if the injected compound is serum insoluble, it will stay in the subcutaneous tissue and be slowly absorbed. After trial and error, they isolated a new protamine from the sperm of rainbow trout, and that had the lowest solubility. Now, how they came to isolate it from the trout of sperm is unfortunately not included in the paper, which, if you ask me, is a historical crime, but we'll let it go. In clinical practice, they found that this insulin was great at controlling basal sugar levels and only needed to be given once per day, most often at bedtime. This was a major breakthrough and was soon followed by another, adding zinc to protamine insulin. This protamine zinc insulin lasted 24 hours and was the first truly long-acting insulin. It was later crystallized by Novo and sold as MPH, starting in 1950. Well, this still left us with only two insulins, regular, or the original, which was rapid-acting, and MPH, or long-acting, with nothing in between. Well, in 1952, Hollis Muller and his team found that if they replaced the citrate, or phosphate buffer used in the insulin preparations with acetate, that the zinc bound much more closely to insulin. This enabled them to get rid of the protamine and meant that they could vary the solubility of preparation by changing how much zinc was added. They were able to produce 3 new insulins with this technique: semi-lenti, lasting 12 to 14 hours, ultra-lenti, lasting over 30 hours, and a mix of the two, or 70-30, that mimicked NPH and was just called lenti. By 1954, this was on the market in the US and led to much greater control options for diabetics. Now, there was still one more barrier to overcome, and that was immunogenicity. All of these insulins were derived from either pigs or cows, and allergic reactions were very common. The holy grail of the insulin world was to somehow create an insulin from humans, and this would eliminate allergic reactions. Now, it would take almost 30 years, but in 1979, David Godel and his group were able to insert the DNA for alpha and beta insulin chains into the E. coli plasmid, and through some truly, thoroughly impressive cellular manipulation, were able to combine the two chains to create human insulin. Now, later, they would take it one step further and actually produce proinsulin and then cleave it to make insulin. In any case, this technology was sold to Eli Lilly, and by July 1980 was being tested in humans, and by October 1982 was approved by the FDA and sold as Humulin. The first version was rapid acting like regular insulin and is labeled Humulin R. Now, this can also be mixed with protamine and zinc to make Humulin NPH or Humulin N. So we have Humulin R and Humulin N. The next major insulin came from Eli Lilly as well. Using the same technology, they switched the last 2 amino acid groups on the beta chain. This blocks the formation of insulin dimers, which means that more insulin is immediately available. This decreased the time to onset and made it the most rapid of the available insulins. This is marketed in the US as Humalog, and that started in 1996. Now, not to be outdone, Novo Nordisk released a similar insulin where the last amino acid is replaced with aspartic acid. This is called Aspart insulin and marketed as Novolog starting in 2000. The last revolution in insulin are the long-acting insulins. These were created in a similar fashion to the logs, but with the opposite effect. By replacing the last amino acid on the alpha chain with glycine and adding our genes onto the end of the beta chain, they were able to create an insulin with no peak and a long duration. This is called glargine insulin and marketed as Lantus. The other insulin in this category is sold as Levemir by Novo Nordisk, and is different than the other insulins because it adds a fatty acid to the beta chain, which makes it bind with albumin in the blood. This complex slowly dissociates, giving a similar profile to Lantus. Now, the very last insulin that we are going to discuss before we wrap up this little session is douglatic insulin, or Tresiba, also from Novo Nordisk. By adding hexadependoic acid to the beta chain, this allows hexamer formation, which significantly delays absorption. All right, so I know that was a lot, but I really find it fascinating. I do want to review the different insulins, and then I promise we're going to get into the management of diabetes in pregnancy. Let's start with rapid-acting insulins. These insulins start working within 15 minutes, peak between 30 and 90 minutes, and act for a total of 3 to 5 hours. These include Novolog and Humalog, which are essentially the same thing, just made by 2 different companies. The log is the important thing to remember there. Humalog, Novolog. The next group is the short-acting. These take effect within 20 minutes, peak between 2.5 to 5 hours, and last about 4 to 8 hours. These are all regular insulin and have a lin at the end, so Humulin R and Novolin R. The next group is our NPH group. Remember, this is a regular insulin with zinc and protamine. These start working in 90 minutes, peak between 4 and 10 hours, and last up to 10 to 18 hours. These are Humulin N and Novolin N. The next group is our long-acting insulins. These start working within 1 to 2 hours, have no peak, and last up to 24 hours, and these are Lantus and Levemir. The last is the ultra-long lasting insulin Tresiba, and is similar to the last two, but can last up to 42 hours. To make things a little bit more confusing, the lins and the logs can also be sold mixed with other insulins. 70-30 is the most common mixture, with 70% NPH and 30% regular. The logs are a mixture of 25% rapid-acting and 75% NPH, like Lispro or Aspart protamine. In both cases, they give you the onset of the rapid with the long-acting of the protamine insulins. So in short, logs are rapid-acting, lins are either regular or NPH depending on the letter after the name, and the Ls are long-acting. So with that primer out of the way, why don't we start to dive into how to manage women with diabetes in pregnancy? As you might imagine, that starts before conception. The better the glycemic control at conception, the better the outcomes. This applies to miscarriage rates, congenital anomalies, and a whole slew of other pregnancy-related outcomes. Some of the next few papers are going to include women with type 1 diabetes, which, as we discussed in the last episode, can lead to much more severe disease. However, at least in early pregnancy, it seems that the risks are mostly tied to the hemoglobin A1C levels and not the type of disease. That may not be the case later in pregnancy, but we'll get there. In any case, for miscarriage rate, The rate goes from 1.3% at a hemoglobin A1C less than 6.5%, doubles at 7.5% to 2.9%, and 4.9% at A1C levels of 8.5% or above. Malformations such as neural tube defects, VSDs, ventral wall defects, cleft palates, aneuploidy, CCAM, diaphragmatic hernia, they follow a similar pattern, with 2.8% in non-diabetics, 3.9% with hemoglobin A1Cs above 6.5%, 4.9% rate of anomalies above 6.9% A1C, and 11% risk of anomalies above 10.4% A1C. In both cases, you can see how there is a substantial jump, even with mild elevations in preconception A1Cs. In fact, although higher values have higher rates, the biggest jump is in that 6.5 to 8% range for A1C levels. Due to these risks, the American Diabetes Association recommends that women planning on getting pregnant achieve an A1C level of under 6%, or at least less than 6.5%. Other factors that should be considered before pregnancy is systemic effects of long-standing diabetes. Now, we spoke in the last episode about White's classification and how it predicted the negative vascular effects of prolonged hyperglycemia. These sequelae should be evaluated ideally before conception. The most common end organ damage is to the kidneys, and so women should have a serum creatinine and a urine albumin to creatinine ratio before pregnancy. These women are also at risk for thyroid disease and should have a TSH level performed as well. All these women should also have an eye exam to look for retinopathy because it can rapidly progress during pregnancy. Lastly, many women with diabetes also have hypertension, and they should be switched to a non-teratogenic medication if needed. In particular, ACE inhibitors, ARBs, and statins should be discontinued as they are all potentially teratogenic. Women with diabetes that are taking oral medications should be switched to insulin during the preconception phase, or at least at the beginning of pregnancy, because outcomes have been noted to be much better with insulin therapy. But before we get into the actual management of glucose levels in pregnancy, I think it's important to step back and talk about the normal physiology of insulin and glucose in pregnancy. In the first trimester, insulin sensitivity is high, glucose levels are low, and insulin requirements drop. During the second and third trimesters, insulin resistance rapidly increases and then levels off for the last few weeks. This means that for women already on insulin, their dosages may need constant adjustment throughout pregnancy. Going back a few sentences, this explains why insulin is preferred to oral, as it is much more readily changed. The target glucose levels for women with diabetes is a fasting level of less than 95 and 1 hour postprandial less than 140, or 2 hour less than 120. The ADA recommends that 50% of the daily insulin requirement should be basal, like MPH, and the other 50% should be short or rapid-acting insulin at mealtimes. AJOG recommends the rapid-acting insulins like Lispro and Aspart because they increase compliance and patient satisfaction and have shown improved outcomes in some trials. They also state that long-acting analogs like Levemir and Lantus are acceptable and have been shown to be non-inferior or even better than MPH in clinical trials. These are guidelines, and each woman will have their own requirements. In addition to insulin therapy, these women need extensive nutritional counseling and weight gain recommendations. One important aside is hypoglycemia, especially in type 1 diabetics. All these targets are great, but they should not come at the cost of significant hypoglycemia because it can lead to maternal coma, seizure, and death. Although these complications are rare, they're obviously bad, and there's also some risk to the fetus. But large studies on hypoglycemia in pregnancy have not been done. Because of the small risk of severe outcome to the mother, the ADA recommends sacrificing some glucose control to limit the amount of hypoglycemia. Now, moving on to antepartum management. The ADA and AJOG do recommend specific items in women with pre-existing diabetes in pregnancy. Due to the higher risk of malformations, they recommend every fetus has a detailed anatomic survey between 18 and 20 weeks, and that fetal echocardiograms be performed on fetuses with concern for abnormalities or with inadequate views on the anatomy scan. They also state that if the resources are available, it's reasonable to get a fetal echo on all women with type 1 or type 2 diabetes. In the third trimester, they recommend a fetal growth scan at 34 to 38 weeks if fetal macrosomia is suspected, and that routine growth scans during the same time frame is acceptable. A 2004 paper by Ehrenberg et al. In AJOG found that 38.3% of women with pre-existing diabetes had macrosomic babies at delivery compared to 11.4% in non-diabetics. Identifying these women early can help raise awareness both for labor and for shoulder dystocia. And speaking of those two items, another paper from Ehrenberg and AJOG found that 35% of women compared to 9.3% of controls had a cesarean delivery. Now, this is likely due to several factors, from fetal intolerance to cephalopelvic disproportion, which is at least in part due to macrosomia. But regardless of fetal weight, but certainly affected by it, these women are also at risk for shoulder dystocia at delivery. A 1998 paper in AJOG by Nesbitt et al. Found that women with diabetes had shoulder dystocia rate of 8.4% with a 4,000-gram baby, compared to 5.3% for non-diabetic women, and at 4,500 grams, it was 20% versus 14.3%. Now, like I said, though, it's not just fetal weight, because even non-macroscopic babies, the rate of shoulder dystocia is higher. This is because babies born to women with diabetes have been found to have abnormal fat deposition, which changes their body habitus. In 1982, Mondanlou et al. Published these findings in the Green Journal. They found that greater than 4,000-gram babies born to mothers without diabetes had a shoulder circumference of 39.5 centimeters on average. In diabetic women, that was 43.5 centimeters, while the head circumference was the same. This same pattern held true at lower weights and most likely accounts for those higher rates of shoulder dystocia that we spoke about. Now, AJOG also recommends some type of fetal assessment, whether it be BPP, modified BPP, or NST, starting at 32 weeks or earlier if concern arises. This is due to the increased risk of stillbirth in these women. A study from Tennant et al. From 2013 spelled this out very nicely. They looked at 397,000 deliveries in England. They found that women with either type 1 or type 2 diabetes had 4 times the rate of stillbirth as compared to non-diabetic controls. Furthermore, the factors they found that correlated most closely was preconception A1C greater than 6.6 and pre-pregnancy retinopathy. Now, if you're paying attention at home, you might be asking yourself, well, since we know that BPPs and NSTs examine only for uteroplacental insufficiency related to stillbirth, do we actually know that's the cause of stillbirth in these cases? Otherwise, we're just wasting our time and money. Well, that's a good question, and I'm glad you asked it. That allows me to talk about one of my favorite papers from this subject, and that's from Nylund et al., and it was published in AJOG in 1982. They took 26 pregnant women with diabetes and 41 pregnant healthy controls and injected them with 1 millicurie of indium-113 and measured uptake by the placenta. They found that women with diabetes had a 35 to 45% reduction in placental blood flow. They hypothesized that the placental abnormalities we discussed in the last episode caused decreased placental perfusion. This, and on the average larger fetal mass, leads to less reserve during times of stress and is likely a significant cause of stillbirth in women with diabetes. This is thought to be a third trimester issue given the rapid increase in fetal size seen in all pregnancies in the third trimester, which is why the recommendation is to start antenatal testing at 32 weeks. Well, next we should consider the optimal time for delivery in women with pre-existing diabetes. Given what we just spoke about, it's easy to see that we are balancing stillbirth and neonatal outcomes. Babies born to women with diabetes are more likely to have RDS, hyperbilirubinemia, and hypoglycemia. Many studies have reported looking at these two factors, and the current recommendation is delivery at 39 weeks in the setting of good glycemic control. If the control is not good, then earlier delivery is indicated because the stillbirth risk outweighs the risk of RDS, etc. Now, while we're talking about labor, I think we should touch upon glucose control during labor. Starting in the late 1970s, teens began to realize that control of hyperglycemia in labor could affect the rates of neonatal hypoglycemia. This makes sense in retrospect because maternal hyperglycemia will induce fetal insulin secretion. Then, when the fetus is delivered and no longer receiving exogenous glucose, the neonate can experience mild to severe hypoglycemia, which in the worst cases can cause neurologic damage. In 1977, Dr. West and Dr. Lowley from St. Thomas Hospital in London reported their trial of continuous insulin infusion, adapted from ketoacidosis treatment, during labor to control glucose levels. In their small trial, they had no cases of neonatal hypoglycemia, and by the early 80s, it was fairly common for women with pre-existing diabetes to be on an insulin drip during pregnancy. Now, I could not find any great studies that determine what the ideal maternal glucose levels during labor should be, but most studies use 90 to 100. This control is achieved by giving an IV drip of regular insulin. When the glucose level is low or normal, then the insulin is turned off and lactated ringers with dextrose is given. This is important because labor is a carbohydrate-intensive process, and we need to ensure that women have adequate access to achieve normal labor and avoid ketoacidosis. As the glucose levels rise, the dextrose is turned off and the insulin turned on. Blood sugars are taken every hour in active labor and every 2 to 4 hours in early labor. There are several different protocols, and I'll link to one in the show notes. This is obviously a very resource-intensive protocol, and some centers reserve it for women with significant antepartum insulin requirements or who develop hyperglycemia during labor. There's really no consensus on who needs it, but here at Stony Brook, where I work, we tend to use it on any type 1 or type 2 diabetic who requires insulin during their pregnancy. And that leads me to the last thing I wanted to talk about in this episode, and that is diabetic ketoacidosis. DKA happens in women with diabetes due to a skewing of a number of physiologic processes in pregnancy. The primary mechanism is the lack of insulin, or relative lack of insulin in the case of insulin resistance, which causes cells to be unable to use the circulating glucose as an energy source. Glucagon, catecholamines, cortisol, and growth hormone are released and tell other tissues to increase the production of alternative energy sources. Muscle, adipose tissue, and the liver respond by producing ketone bodies and more glucose. The glucose from hepatic gluconeogenesis worsens the hyperglycemia, feeding back into this cycle. The ketone bodies are also made by the liver from free fatty acid chains secreted by adipose tissues. Two main ketones are made, beta-hydroxybutyrate and acetoacetone. In DKA, this has been shown to happen at a 10-to-1 ratio, which is why we use beta-hydroxybutyrate clinically. Acetoacetate is then decarboxylated to acetone and secreted through the lungs, giving women in DKA that fruity smell to their breath. Ketones, in addition to acting as an energy source, are also organic acids. Now, in normal quantities, they're buffered by bicarb, but in DKA, they appear in such high concentrations that they overcome this natural buffer and cause a metabolic acidosis with a high anion gap. The last aspect of DKA I want to touch on is dehydration. As the glucose levels rise, the kidney effectively maxes out on how much it can reabsorb from the tubules. Because glucose is osmotic, it drags water with it into the collecting system and causes polyuria. This leads to hypovolemia, hyperosmolality, and also electrolyte depletion because ketones are often bound to sodium and potassium, so as they get pulled into the urine along with everything else, they take those electrolytes with them. Pregnant women with DKA present with dehydration, ketosis, and acidosis. Get it? DKA. In non-pregnant DKA, the glucose levels are almost always very high. But due to the adaptations of pregnancy, women with DKA often present with only moderately elevated serum glucose levels. In pregnancy, the most common trigger for DKA is stopping previous insulin therapy, next is infection, and the last is iatrogenic due to either terbutaline or steroid administration. In the mothers, DKA leads to dehydration, organ dysfunction due to acidosis, and severe electrolyte imbalance leading to cardiac arrhythmias. For the fetus, the threat is multifold. First is decreased perfusion due to maternal hypovolemia and the constrictive effects of the acidosis on the vasculature. The lower pH also increases maternal hemoglobin affinity for oxygen, which decreases the amount transported to the fetus. This results in decreased fetal heart rate variability, accelerations, an increase in late decelerations, and in severe and long-lasting events, stillbirth. That being said, the mother needs to be resuscitated first, and then if fetal condition is still poor, then delivery can be considered. Labor or surgery in a woman with DKA puts her at a significant risk for severe morbidity and mortality, and therefore the mother should always be stabilized first. On presentation, women should have an arterial blood gas, serum glucose, serum ketones including beta-hydroxybutyrate, a chemistry panel, urinalysis, urine culture, and urine ketones. Then first, if infection is the possible inciting event, antibiotics should be started. The remainder of the treatment is aimed at fixing the underlying disorders. We need to reverse the hypervolemia, decrease the serum glucose, correct the ketoacidosis, and correct the electrolyte imbalance. The goal is to replace 75% of the fluid deficit in the first 24 hours. We start with normal saline and then adjust according to sodium and chloride levels to prevent hypernatremia or hyperkalemia. We then give insulin, starting as a bolus, and then decreasing as glucose levels decrease. The goal is for a serum glucose level of 60 to 75. Once glucose levels are below 250, we start adding back glucose to avoid hypoglycemia. Ketones and anion gap are monitored every 2 hours, and insulin is continued until that gap resolves. Lastly, potassium will often need to be replaced, and the goal should be serum level of 4. Some people have recommended also replacing phosphate, magnesium, and calcium, but the data is really mixed on efficacy. Most clinicians now believe that these will replete on their own and they do not need to be replaced. The main thing with DKA is early recognition and treatment. This may mean an MFM or MICU consult or transfer to a different hospital where an ICU setting is available. Fluids and insulin are the main treatments, and as maternal status improves, the neonatal status should also. And I think that's it for today. I do apologize for the long delay in getting this episode out. The last episode in this series will be about gestational diabetes, and I hope that'll be less than a year before that comes out, but no promises. I want to thank you all again for listening. If you have questions or comments, or you want to suggest topics, please send them to feedback@obgyn.fm, and please join the Discord server. Come talk to us and connect with your colleagues all over the world. Thank you.